if I click out of that, is it gonna? Okay. All right. Good morning, everybody. This is Heather, and I am going to be facilitating today's training for PDPM. We want to give you some housekeeping instructions to get started so that you can receive 1 hour of continuing education. You should have a sign-in sheet where you need to sign in your name and your signature, and then the third column should actually say license. So if you could just cross off campus and then put your license number there so that you can claim 1 continuing education credit for today's training. It would be helpful if you wrote up at the top which campus you will be sending this sign-in sheet to us from. That would be helpful as well. The other requirements for the CE are to participate in the entire webinar, complete and submit the evaluation, complete and submit the quiz, passing with an 80% or greater. And if you have questions throughout our time, you can submit those through the chat function. We want everybody to silence your microphones on your side so you can hear me, but I can't hear you. So the communication is going to be through the chat function on your end. If you are listening to this as a recorded webinar, then you can contact the education team with any questions that you might have. The number and the email is listed there for you. So that is our housekeeping to get started. Okay, so this is our patient-driven payment model session, care and documentation of neurological disorders. The objectives for this session. Somebody.
Can we make a copy of the test?
Okay.
For your
If you want to start out and see if there's anyone else that can start. Okay, so these are our objectives. So we're going to be talking about several different neurological disorders: stroke, Parkinson's disease, peripheral neuropathy, multiple sclerosis, amyotrophic lateral sclerosis, and cerebral palsy. And the reason that we're talking about these specifically is because they all factor into the nursing case mix index and the non-therapy ancillary case mix index with the PDPM model. So for each of these, we're going to describe the disease, including causes and symptoms, discuss treatment and care, and then apply that knowledge to thoroughly document all nursing care. Because as we've all been learning, and that includes me as well, the emphasis is going to be on documenting, providing evidence of the care that we are providing, and that all relates back to this new reimbursement model. Okay, so we're going to begin with stroke. Of course, we know that there are 2 different types of stroke. The first one being the ischemic type, where a blood vessel is blocked and a portion of the brain is not receiving oxygenated blood. That is what the picture on the right-hand side is depicting, that an actual clot or plaque has occluded the blood vessel. And so then you can see from the picture the portion of the brain that is darkened and have deficits related to that part of the brain and its damage. The other type of stroke is the hemorrhagic stroke, so where we see bleeding into the brain itself or around the brain, where pressure is being put on the brain, and that causes brain damage as well. It is imaging that is going to tell us which type of stroke we're dealing with, and that of course will help to dictate what kind of emergent treatment can be administered. Okay, so looking at the contributing factors or causes for stroke, high blood pressure or hypertension, atrial fibrillation is huge. We talked about that in our cardiac session, where when little blood clots develop in the heart and then are thrown from the heart, they can go to the brain and cause a stroke. Carotid or other artery disease, high cholesterol, diabetes, smoking, Physical inactivity, obesity, and sleep apnea are all related to stroke risk. Okay, so these symptoms, the acute symptoms of a stroke. Obviously, a stroke is an emergency situation and one that we need to be able to identify quickly and transfer the person for acute care. The acronym that we're showing you here is a simple way to remember how to look for a stroke or spot a stroke fast. The F standing for the face. As you can see the picture, this person is exhibiting facial droop. So one side of the face is weakened and drooping. Arms. The A in this acronym stands for arms. Can the person raise both of their arms? Does one arm drift off to the side when we ask them to raise those arms? The S stands for speech. So is the speech slurred or strange? And then the T is really important as well, the time. We need to note the time that we observe the first signs and call 911 immediately. Noting the time of those symptoms is going to be very important to report to the hospital because once again, that is going to Neurologists will get very detailed into what exactly is the nature. Can everyone hear me? Everyone, could you let me know if, oh, so it was, they were hearing me and then they were not? Oh, shall I start over? Oh boy, we missed the last two slides. Huh. Okay, everybody. I apologize. It looks like somehow the system muted me. I apologize. Let's go back a couple of slides then. I don't have the back arrow. Okay. If I hit escape, I'm just going to get out of the view. Am I going to be okay to hit escape?
If you can just back up your slide.
I can't. I don't have an arrow down here to hit backwards. This is not working. Go ahead.
Yeah, you can escape it and start.
Okay, everybody, we're going to back up a little bit. Thank you. Back to the acute symptoms. Okay, so we were talking about spotting a stroke fast using the acronym FAST, the F standing for the face. Does one side of the face droop, as you can see in the picture? The A standing for arms. So is the person able to raise both of their arms and keep them there, or does one arm drift to the side? The S stands for speech. Is their speech slurred or strange? And then the T standing for the time. So it is important that you note the time that symptoms began, the time of the first symptom, and that we call 911 immediately because we spotted a stroke, we've spotted it fast, and now it's time for intervention. So just developing that a little bit further, sudden onset of symptoms. So a sudden numbness or weakness of the face, arm, or leg, especially on one side of the body. Sudden confusion. Sudden difficulty speaking or understanding speech, seeing in one or both eyes, walking, dizziness, loss of balance or coordination, sudden severe headache without a known cause. So again, recognizing that these are a medical emergency and we need to call 911. There are interventions that can save this person's function if we get them there quick enough. Okay, so what we're going to be dealing with mostly on our end is dealing with persistent symptoms. And the persistent symptoms really relate directly to the portion of the brain that was injured during the stroke. So functional deficits that we may be compensating for, helping the person to compensate for, include one-sided weakness or paralysis, foot drop, spine contraction, poor balance, fall risk, fear of falling, incontinence, and dysphagia, so possibly leading to aspiration pneumonia. Other persistent symptoms may include difficulty giving and or receiving communication. So that is kind of the big picture. The speech language pathologist will get very specific about the exact nature of the communication deficits and overcoming those. Aphasia is, the common term for communication problems after a stroke. It might be expressive, so they may know what they want to say but have trouble saying it. It may be receptive, where they are actually having trouble understanding the words that other people are speaking. It might be global, so difficulty giving and receiving language. Dysarthria and praxia both have more to do with the motor control. So with dysarthria, they may have trouble with the muscles of the face, tongue, and mouth. So you might have somebody who is speaking slowly, slurred, muffled, hoarse, or nasal. And then again with apraxia, trouble connecting the speech messages from the brain to their mouth. Again, difficulty with voluntary movement for speech. Persistent symptoms might also include sensory issues, so vision changes, auditory overload, which basically is sort of being overwhelmed by stimuli and affecting their concentration, decreased sensitivity to pressure, which increases the risk for pressure injury. They may have cognitive symptoms, so thinking, awareness, attention, learning, judgment, memory, orientation. We could even talk here about vascular dementia, which could develop over time. We may be dealing with that as well. Behavior, inability to inhibit undesirable behavior, personality changes. Pain, numbness, or strange sensations, often worse in the hands and feet, might be worse with movement, might be worse with temperature changes, especially cold. And then the emotional component. I think for all of these that we're going to be talking about, there's an emotional component. That component may be directly related to the brain damage, or it might be related to, or also related to just dealing with the life changes that come about because of these neurological disorders. Okay, so part of post-stroke care really is understanding what went on in the acute care setting. Um, a client who was treated for a stroke recently may have received anticoagulants, right? So the first three here relate to the ischemic stroke. So they might have been on heparin in the hospital, been started on the oral anticoagulants. They may have received TPA, which is a medication that dissolves the clot. The anticoagulants stop the clot from getting bigger and allow the body to begin dissolving it. But TPA actually goes in and dissolves that clot. They may have had a procedure to retrieve the clot called a mechanical thrombectomy. So all of those relate to ischemic stroke, or they may have had a procedure to place a coil to stop bleeding from a ruptured artery, or even had surgery to secure a blood vessel at the base of an aneurysm. So there's a variety of things that they may have already gone through in the acute care setting before they reach us, and we definitely need to know what they have had because that'll affect our management as well. All right, so post-stroke care, typically we're thinking for a period of time, they say approximately 3 months, but it can be longer than that, where we're really focusing on this person's recovery. Because of inflammation that needs to go down over time, because the brain is capable of healing itself to some degree, there's a time frame where we're working with somebody and we don't consider them to be at their new baseline yet. So we're really thinking about recovery. And then there comes a point where we kind of turn a corner. We recognize that these are going to be persistent deficits for this person, and these are going to be lifelong issues that they have to kind of compensate for. So post-stroke care is very complex. We're going to be looking at functional assessments, determining their deficits, also, of course, looking for those strengths. Um, Rehabilitation and restorative care, assessing the specific deficits, and that's going to apply really to all of the things that we're talking about. We're looking at each individual person, we're looking at their unique deficits and their unique strengths, and we're looking at how can we support and compensate for those things. Restorative continence care, balance training, individualized exercise, pain management, sleep hygiene. Also looking at medical management. So whenever we're talking here about medications, medications carry with it a lot of oversight. We're watching for the effects. We're watching for the side effects. In the case of Coumadin, of course, it requires tight management with lab work and things like that. Also dietary considerations with Coumadin. Cardiovascular medical management, that atrial fib you see there increases the risk of stroke by 4 to 6 times. So managing AFib, lowering cholesterol, hypertension, diabetes, seizure prevention, and depression. So those were all sort of medical management, and now the combination with that always are the lifestyle choices that people can make to help themselves. So about 25% of people will have another stroke within 5 years, and of course we can minimize that by making these lifestyle choices. What's our role in that, of course, is education. There's a lot of education and a lot of support for the person to make these choices and make these changes. So stop smoking, increase physical activity, healthy diet, healthy weight, heart healthy diet, and limiting alcohol. So this in the red here is words that you're going to see over and over throughout the rest of the session. The encouragement and the necessity here is to document all of your assessments, all interventions, client responses, education, and communications. So essentially, we've got to take credit for all of the management for each of the people that we're talking about here. The documentation has to support and give evidence for our claims for reimbursement. So, what are we doing? What are we as nurses doing to encourage a complete recovery or the best possible recovery following a new stroke? How can we help prevent another stroke and help the person adapt to any persistent deficits? Those are kind of some big global questions. I'm going to give you some more specifics. So as we are managing all of those contributing chronic, we are managing stroke. So all of that has to get documented. That includes, of course, the cardiovascular, that fib, the diabetes, and so on. The medical management, the medications, particularly Coumadin, but others as well, lifestyle, vitals, splint a brace, mental wellness, and psychiatric issues. Those play a big part in wellness too. And ultimately, how are we addressing the specific challenges that this person is facing? So challenges with communication, the type and amount of functional and ADL support, the eating, nutrition, hydration. What challenges do they have? How are we compensating? What about mobility, fall risk, pressure injury prevention, pain elimination, and cognition? So all of those things are a part of our documentation. Okay, so moving on to talk a little bit about the next disorder, which is Parkinson's disease. So Parkinson's disease is a chronic, progressive motor system. Now, this results from a lack of dopamine in the brain ultimately. The brain cells that produce dopamine are diminishing, and that creates for us motor symptoms. And I think that that's what we mostly think of. We mostly think of the motor symptoms of Parkinson's disease. But there's also non-motor symptoms, and that has to do with a different neurotransmitter called norepinephrine. So there's a lack of norepinephrine as well, and that contributes to non-motor symptoms, and we'll talk about that. And finally, there's a third component of this Parkinson's disease, and that has to do with the protein alpha-synuclein. Um, so that is a protein that is in abundance in the brain, and it's supposed to be there. The problem is that the brain stops doing its job of using the protein and then clearing the protein, and it begins clumping and building up into these things called Lewy bodies, and then that also contributes to inflammation in the brain and brain damage. So the cause of Parkinson's disease is unknown, but it's likely a combination of genetics and environment. And we've given you a couple of examples there: exposure to pesticides, certain heavy metals, and repeated head injuries. And we've seen that with like Muhammad Ali, boxers, football players. We've seen that. So the symptoms will progress at variable rates and degrees for each person. The symptoms, the motor symptoms, often begin on one side or in one limb and may eventually affect both sides, but will typically remain more prevalent, more severe on the side they began. So these are the four major motor symptoms for Parkinson's disease. The first one is the one that we think of most often. It's that resting tremor. It may be in the hands, feet, leg, jaw, chin, mouth, tongue, or face. They also have rigidity or stiffness of the muscles, bradykinesia, which means slowness of movement, and impaired balance and coordination. And really all of these work together to increase fall risk. So these motor symptoms can cause difficulty with completing simple tasks and daily activities, walking. They have a pretty characteristic Parkinsonian gait. We see them leaning forward, taking small, quick steps, and a reduced arm swing. It's a pretty characteristic sign. Initiating or continuing movement, talking, chewing, and swallowing can be a problem. And the face that you see on the side there is the mask-like face that can develop with a person who has Parkinson's disease. We show you that because it might look like the person is not paying attention, is disinterested, is not able to process, but really all that it is there's a lack of muscle strength to use facial expression. And so we need to recognize that. Okay, so here are the non-movement symptoms that you might not think about too much when you're working with people with Parkinson's, but they are important. So irregular blood pressure, particularly orthostatic, urination may be a problem, frequency, urgency, hesitancy, retention, constipation, sleep, skin problems, particularly melanoma. I thought that was very interesting. Psychosis, personality changes, and then there's those emotional changes that we said are going to come up each time. Depression, anxiety, and even fatigue. They kind of categorize this under emotional. Emotional fatigue goes along with physical fatigue as well. So there are some medications on the market. I'm sure you're pretty familiar with several of these, if not all of these. Um, the ones that we've listed here, the majority of them are working to increase the amount of available dopamine in the person's brain. You probably see the top one most often, the Sinemet or carbidopa, levodopa. The others work similarly. The anticholinergic down there, Cogentin, is an old medication that I know is still being used. Um, so these are medications that do have an effect on the motor activity. Again, increasing the amount of dopamine in the brain is going to help with those motor symptoms. Um, One interesting thing that they can utilize is deep brain stimulation. So where electrodes are actually implanted into the brain and connected to a pacemaker-like device. And you can see that in the picture there. This is basically used for fluctuations, severe fluctuations, significant fluctuations in motor, and also medication-resistant tremor. So if they've tried the medications that we listed previously and not getting good results, and the motor activity really impairing quality of life, this may be an option. Okay, so treatment, always a collaboration between physical therapy, occupational therapy, and the management of the individual symptoms. Fall risk is going to be a big issue, so managing that. Lifestyle changes, healthy diet, exercise program. They really emphasize the need for all of these elements of exercise. Fitness training, strength training, stretches, gait and balance training. They all work together. And then complementary therapies, they did say, are not necessarily scientifically evidenced. However, anecdotally, people find relief with things like yoga, massage, acupuncture, and acupressure. All right, then here's our slides on documentation. Going back to basically whatever we're doing to manage the medications, the lifestyle, the complementary therapies, vital signs, mental wellness, psychiatric issues. Whatever we're doing to help manage, we need to document. What are the challenge? How are we addressing them? Are there communication issues, functional issues, the type and amount of the support? Again, nutrition and hydration, mobility, pain, elimination, and cognition. All right, moving on to talk about the next one, which is peripheral neuropathy. So peripheral neuropathy refers to conditions that involve damage to the peripheral nervous system. This is a vast communication network that sends signals between the central nervous system, which is, of course, the brain and spinal cord, and all other parts of the body. I really liked the picture just because it was very, very basic. It reminded me of just how vast that communication network is. If you're like me, you might think mostly of the feet or maybe the feet and hands when we talk about peripheral neuropathy. But the truth of the matter is that it really does affect all of the body, and you can see that by the blue components there. The peripheral nervous system is a vast network. Causes, there are two slides on causes. There are a lot of contributing factors to this. It says at the top, correcting the underlying cause can resolve the neuropathy. Obviously, that would be if we're catching that very early to resolve the neuropathy. Or we can prevent further nerve damage, which is good. That gives us hope that the better job we do at managing the underlying causes, the more help we can give with the neuropathy itself. So diabetes, of course, is the leading cause in the United States. Other problems include these autoimmune diseases such as lupus and rheumatoid arthritis and so on. Certain infections, Lyme disease, shingles, and others listed there. Other diseases, kidney disease, liver, connective tissue disorders, and hypothyroidism. We see a lot of thyroid issues. Vascular problems, our nerves need oxygen supply by the blood as well as everything else in the body. So same sort of thing, high blood pressure, atherosclerosis, smoking, all contribute to peripheral neuropathy. Tumors, alcoholism, certain toxic substances, exposure to those, medical chemotherapy. I've heard that often. People who've been treated successfully for cancer but are left with neuropathies to deal with. Trauma or nerve pressure. And then finally, there are certain vitamins that are needed for nerve health. Certain B vitamins here, B1, 6, and 12, and also vitamin E and niacin. So once again, if you're like me, you mostly think of the sensory issues with peripheral neuropathy because that's what we so much of. It's much easier to see the sensory compartment of this. So the sensory nerves transmit information from the skin. So things like light, touch, temperature, and pain are transmitted. The pain that they experience is neuropathic pain. So it's described prickling, tingling, sometimes sharp jabbing or throbbing, itching, burning, pins and needles, those kinds of descriptors. And that's why we put the little cactus over here with the feet on it, because that's kind of what they feel, that prickly pain. They may have extreme sensitivity to touch. An example I've used a number of times is knowing when somebody has had shingles because that area may remain, they may have damage to the nerves in that area and it may be very, very sensitive to touch. They also have a loss of the protective sensation. So hypersensitive in some areas, but a loss of the needed sensation, especially to their feet, loss of reflexes, and a loss of position sense. So these are the other parts. So it's the sensory nerves, but it's also the motor nerves. So the motor nerves, of course, control the movement of the muscles under conscious control. So things like walking, grasping, and talking. So if the motor nerves are affected, we see muscle weakness, muscle twitching, painful cramps, loss of coordination. And then the third type of nerves, peripheral nerves, is the autonomic nerve. So this controls functions that are not under conscious control. So things like blood pressure, heart rate, digestion, and bladder. So what are we going to see? Of course, changes in the blood pressure, dizziness, lightheadedness, bowel, bladder, and digestive problems, heat intolerance, excessive sweating, or not being able to sweat. Autonomic. So most neuropathies affect all three types of these nerve fibers. So this is why we hear about polyneuropathy. Others primarily affect one or two types. So you might see it written in doctor's notes or something, predominantly motor, predominantly sensory. You may hear sensory motor neuropathy or even autonomic. Okay, so we're back to our red slide, reminding us to document all of our assessments, interventions, responses, education, and communications where all of these things are concerned. So anytime we're managing the contributing chronic diseases, we're managing the peripheral neuropathy, management of that pain. Oftentimes they're using antidepressants, anticonvulsants in terms of medication therapy, also local anesthetics. We see a lot of lidocaine patches that seem to be helpful. TENS units. So this is that electrical nerve stimulation. The oddity of the fact that stimulating the nerves can be helpful is interesting. And of course, pain management isn't just about the medications, it's also about all of our non-drug interventions as well. So again, the type of functional support, sleep, quality, skin, pressure injury prevention is huge, and of course, particularly with foot care and other wounds. Uh, Taking care of the feet, monitoring the feet, cleaning the feet, moisturizing the feet, all of those are very important. Preventing from injury, again, because they lack the protective sensation. So, scalding, bath temperatures, and mobility balance coordination in all of our fall risk modifications. Infection prevention is important. Monitoring vital signs and changes in blood pressure, so dizziness, lightheadedness. Education here for slow position change. Stop smoking, bowel bladder digestive issues, and mental wellness, depression, anxiety, and other. Each of these is complex scenarios, and they require a lot of work, and that's why it's a good thing that we're going to be getting credit for the work that we're doing. Okay, moving on to talk a little bit about multiple sclerosis, or MS. So MS is an autoimmune disease of the central nervous system. So what is happening that the actual neurons are being attacked. The specific part that's being attacked is this myelin sheath that's supposed to be a protective coating for the axons. And so the body mistakenly, immune system mistakenly treats that myelin as if it's a foreign body and begins to destroy it. And as it does so, it creates inflammation along the axon, and then the axons themselves become damaged, the nerve cells become damaged as well. And so the outcome there is that smooth flow of the nerve impulses and communication between the brain and the body is disrupted. And that's why we see the symptoms of MS. This is just a simple picture of a nerve cell where you can see the normal on the left. That myelin sheath is protected. On the right-hand side, you can see the sheath is becoming damaged over time, and ultimately, with the inflammation that ensues, the whole nerve can be damaged. So what do they do to diagnose this? Well, a big part of the diagnosis is going to be MRI. And also following along the progress, they may use MRI as well. So what they look for are lesions and plaques. And a lot of the literature kind of uses them interchangeably. The one that I referenced kind of differentiates lesions as areas of inflammation and damage. Size, number, and location may help to determine the type and severity of the symptoms. The plaques are thick scar tissue that forms along the areas of permanently damaged myelin. So they're looking for lesions, they're looking for plaques on the MRI. This remyelination is a process to repair the damaged myelin, and that's the body's own process. The body works to try to repair that protective coating. Okay, so those are some definitions for you. Okay, so the types and severity of symptoms will differ greatly between people with MS. People with MS experience what we call flare-ups and remissions. So symptom flare-up, and as you read about these things, the flare-up is also known as a relapse, an exacerbation, or an attack. They all kind of refer back to the same thing, a symptom flare-up. So this might include new symptoms, symptoms the person has not had before, or an increase in existing symptoms. And then they make this distinction that these symptoms are present for at least 24 to 48 hours without signs of infection or fever. And I'm going to show you why we have to have that in there as part of that definition when we talk about pseudo-exacerbation in just a moment. So we've got symptom flare-ups, new symptoms or an increase in existing symptoms, and then we have a time of remission. So this is a complete or a partial recovery period following a symptom flare-up. Some people with MS experience steady progression and they don't have these periodic flare-ups and exacerbations or flare-ups and remissions, flare-ups and remissions. Okay, let's look at that last definition there. So this pseudo-exacerbation, it's a temporary worsening of symptoms without myelin inflammation or damage. And it's due to a variety of things. Illness, infection, UTI being the most common, exercise, a warm environment, depression, exhaustion, or stress. So what we're saying there is that a person who has MS can begin to experience what looks like a flare-up, but really it's related to something else, like we've just listed here, like an illness or an infection or so on. So that's why it's important to distinguish at the top symptoms that are present for at least 24 to 48 hours without signs of infection or fever. We're trying to differentiate a true symptom flare-up, which we're going to treat one way, versus a pseudo exacerbation, which we need to treat the underlying cause. Okay, so some common physical symptoms. There are many, 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 many. 3 slides of common physical or common symptoms. These are physical symptoms. So balance, mobility, walking problems, bladder dysfunction, bowel problems. Heat intolerance, that's something really that's kind of unique to this particular one, is they really have trouble with heat intolerance, and it can actually cause a pseudo exacerbation like we just saw on the previous slide. Sexual dysfunction, spasticity or stiffness, speech difficulties, swallowing disorders, and tremors. Common physical symptoms. Common emotional, mental, and psychological symptoms, anxiety. Some experience cognitive changes, particularly the speed of information processing, memory, and executive functions. Depression, and pseudobulbar affect, which is a sudden uncontrollable expression of laughter or crying. That pseudobulbar effect comes up a few times with these different disorders. Other common symptoms, and they kind of refer to these as silent symptoms, symptoms that the person suffers with that aren't obvious necessarily to the outside person, but very, very significant to them. So dizziness, vertigo. The second one there is fatigue. So because of this problem with transmitting the nerve signals, they tend to, hold on a minute. Excuse me. I almost lost power, guys. They tend to have this overwhelming sense of tiredness, the overwhelming sense of fatigue. So this can lead to deconditioning, and it may actually be disabling for them. So fatigue is a very significant symptom that has to be managed. Sleep issues, numbness, pain, which can be either neurogenic pain or nociceptive pain, visual disorders, and weakness. So the really, really, really good news about MS is that we do have some long-term treatments that are actually disease-modifying therapies. So this is really good news. 17 different medications, FDA approved, on the market, that can make a real difference in this person's quality of life. So slowing the disease activity, delaying the progression and disability, increasing longevity, and reducing the severity and frequency of the flare-ups. So a big component is going to be medication management. Then this is where we're talking about a true flare-up. So if there is a true severe symptom flare-up, they usually treat that with steroids. So going back to our conversation about the pseudo-exacerbation, you wouldn't want to be giving somebody steroids if there's an underlying problem that we need to be treating instead. So this is why that's important to make that distinction. So steroids is usually, there's also this other medication that's on the market, which is highly purified form of ACTH, and this is an injectable, so it has to be injected into the muscle or the skin daily for 2 to 3 weeks, if that is the route we're going to go. Okay, so back to treatment, back to individualized symptom management. We collaborate, right? We're collaborating with PT and OT always. We said energy management is going to be a big thing for these folks to manage that fatigue so that they can stay active, so that they can not become deconditioned, so that they don't fall into disability. So the 4Ps are principles that we can apply. I think they're pretty self-evident. The idea of pacing activities, um, idea of prioritizing the most important thing, planning to be able to do so, and also positioning. So positioning has to do with how you actually position things in your environment and how you position yourself. So applying these principles of 4Ps to manage your energy, manage the fatigue. So teaching about those things is going to be helpful. Therapeutic exercise, stretching, gait training, and medical devices may come into play. Supportive light footwear, pain management, speech therapy. So continued individualized symptom management, healthy diet, altered consistency may at some point be necessary because of swallowing issues, counseling, stress reduction techniques for anxiety management, behavior modification, for example, bowel and bladder dysfunction, good sleep practices, complementary and alternative things like relaxation, deep breathing, guided imagery. Avoiding overheating. Remember we said overheating can cause a pseudo exacerbation. So they actually have things on the market that are like garments that control the cooling for that person. Controlled cooling through passive cooling garments. And then of course those medications. So how are we addressing the challenges for this particular person? The physical symptoms, the emotional, mental, and psychological symptoms, other silent symptoms, and then of course the type and amount of functional and ADL support necessary. All right. So we're going to refer to this one as ALS. A lot easier to say ALS than to speak the whole thing out. This, of course, is a progressive neurodegenerative disease as well, progressive. So we know that this is progressive. It affects motor neurons only. The muscles gradually weaken, and eventually the brain cannot initiate or control voluntary movement. Complete paralysis is possible in the later stages. Approximately 82% of these folks die related to respiratory failure, and the life expectancy averages 2 to 5 years from the time of diagnosis. So 90% of the cases occur without a family history, and the cause is unknown. 90%. 10% of these cases are inherited through a mutated gene. And this is interesting. I do not know why. Veterans who served in peacetime or war are more likely to get ALS. I do not know why. It's interesting, though, and sad. Okay, so there is a variable presentation and progression for ALS. Often begins with weakness in the arms, hands, legs, or in the muscles that control speech and swallowing, which increases choking risks and really causes us to be looking at nutrition early. Eventually, people may lose the ability to speak, eat, move, and breathe. Pain, spasticity from muscle cramping, drooling, and constipation are also common symptoms. And behavioral and emotional disturbances, including that pseudo-bar effect, are possible as this disease progresses. So this is interesting. The muscles of the eyes and bladder are generally not affected. The senses remain intact, so they are able to see, feel, hear, taste, and smell, even in the latest stages. Cognition and personality may also remain intact. So we need to be really careful that we're not making assumptions about this person, that they are unable to communicate. We may have to get very creative in how we communicate, and there are lots of devices and things like that that are available to help this person continue to be able to communicate their needs, desires, and preferences. Um, do not assume that the person can't feel, including pain, and do not assume that the person isn't able to think, decide, or remember. As a matter of fact, one of the key things that we need to do is give this person as much control as possible over their care. They actually tend to have a very strong need to be able to control the details about their care, and we need to acknowledge that. So there is no cure for ALS. There are a few medications on the market, but truly it's buying a little bit of time typically. Of course, we will try them. The person may respond very well. Um, they may slow the progression, may delay the need for the tracheostomy, may improve the speech and swallowing. Um, they are approved, they are FDA approved, they are on the market, they should be given their due diligence. But truly, they don't. It's not like with MS where we've got someone that we can really modify that disease. There are also, of course, medications for the other symptoms: pain, drooling, spasticity, muscle cramps, anxiety, and depression. So, medications for those things, treatment for those things. We have on the side there that rest, reposition, warm packs, or massage may really be helpful with muscle cramps and spasticity. So, a big part of this is respiratory, trying to help this person continue to breathe effectively and clear their own secretions for as long as possible. So, there is this diaphragm pacing system, which can improve respirations using implanted electrodes to stimulate the contraction of the diaphragm. So I've got a picture here for you to see. So there's the electrodes that are implanted. They are connected to the diaphragm. Again, there's an external sort of a pacemaker type device, and it can stimulate the contraction of the diaphragm that can help them to have a more effective respiration. There's also non-invasive ventilation. So the one that we're probably most familiar with is CPAP. So this is a non-surgical way to support this person's breathing. Then there's something called assisted coughing. And so what this has to do with is positive pressure. It's a device that provides positive pressure with then a quick switch to negative pressure. So it blows in with pressure and then sucks out. Ultimately, that's what it does. There's negative pressure to try to help them clear the mucus, clear the secretions, not get pneumonia. And then ultimately, tracheostomy and mechanical ventilation will have to be considered for most of these folks at some point along. Um, will they want to undergo that surgery and go that direction, or will we be talking about hospice closer to the end? And of course, we need to know this person's wishes, desires, preferences as early as possible, facilitating these kinds of conversations, with the family, with the person, so that when we come to that point, we know how to best support them. You do need to take note of this warning that the delivery of oxygen can actually suppress their respirations and is generally not used except for a comfort measure in those terminal phases. So we usually think of providing oxygen to help, but in the case of ALS, it can actually make things worse because we suppress their drive to breathe. So treatment, we collaborate again with physical therapy, occupational therapy, speech therapy, or the speech language pathologist, um, in terms of assessments, evaluations, and interventions to help with the ever-changing deficits that they're dealing with. The dietitian also is going to be very helpful for nutritional support and enteral support. And by the way, that's another decision that will have to be thought about, is whether or not to move toward a feeding tube. Um, you know, if the very early symptoms have to do with swallowing, then it may very well be that the right thing to do, if the person determines that it is so, is to have a feeding tube so that they can get the nutrition they need, get the medications that they need early on, even in this process, if the symptoms include swallowing early. And then at the bottom, we already mentioned, when is it time for hospice? And the whole family is going to be in need of our support. Okay, so how are we addressing the challenges that this person is facing? Respiratory support here is on the top of this particular list, so assisted coughing and support. Infection prevention, the pneumococcal influenza vaccines will be offered, of course. Communication, and OT can help us get started with communication strategies. They really recommend doing that very early, by the way. While the person still has their abilities, start early working with the communication aids. The type and amount of assistance for function in ADL: eating, mobility, fall risk, pressure injury prevention, pain, spasticity, muscle cramping, elimination, mental wellness, changes in behavior, and cognition. All right, and then finally, this is the last of our neurologic disorders that we're discussing today. Cerebral palsy is a group of neurological disorders appearing in infancy or early childhood and permanently affecting body movement, muscle coordination, and balance. So, people with cerebral palsy have a complex and unique presentation. There are different types. There's the spastic type, which shows increased muscle tone, stiff, awkward movements. The dyskinetic type, altered motor patterns, so slow, uncontrollable, or jerky sort of movements. Ataxic mostly affects balance, depth perception, and coordination. And then there's, of course, a mixed version where there's a combination of one or more of the above. Disability for this can range from really very mild, where it's almost unrecognizable, to very severe. So the brain damage that happens during the pregnancy, during the childbirth, or early in infancy is not progressive. It's not a progressive brain damage, which is interesting. That's unlike some of the others that we've already talked about, which we know are progressive brain disorders. However, complications that arise can be progressive, and particularly if they are not managed well. Common symptoms with cerebral palsy: of course, abnormal movements, stiff, spastic, or floppy muscles, a lack of muscle coordination, speech and swallowing problems, and drooling can be a problem, gait, pain, seizures. Other symptoms might include cognitive deficits, hearing loss, impaired vision, bladder and bowel control, and constipation. So the older adults that we see with cerebral palsy may also experience depression and osteoporosis. And then this next one, osteoarthritis and degenerative arthritis. I don't know about you, but watching folks with cerebral palsy navigate life and just imagining, the use of those joints and muscles over time, I can really see how those abnormal forces would cause this. There is a post-impairment syndrome, which just kind of groups together the most common chronic symptoms that we see: pain, fatigue, weakness due to the muscle abnormalities, bone deformities, repetitive motion injuries, and arthritis. There's no cure for cerebral palsy. Drug and non-drug pain management is going to be key. Also, medications to control seizures or relax muscle spasms. Sometimes people have surgery to correct anatomical abnormalities or to release tight muscles. Exercise is going to be also key, strengthening endurance, flexibility, balance, and cardiovascular health. PT and OT, uh, we may be using braces, orthotics, rolling walk, adaptive devices that are assistive, that help with function and movement. Massage therapy facilitates the lymphatic and circulatory systems as well as the musculoskeletal system, and can help manage pain. Chiropractic care, speech therapy, communication aids, music, community social engagement, therapy, and counseling. All right, so our final slide here where we're reminding you about the documentation for all of these things, thinking through how are we addressing the individual challenge this person is having, what are the pain issues, how are we resolving that? Our exercise, mobility, and so on. Nutrition, hydration, elimination, communication, type and amount of functional support, mental wellness, changes in behavior, cognition, and infection prevention. All right. And so I'm just bringing back up here that slide with the instructions on how to receive 1 hour of continuing education, making sure everybody has signed in, given us your license number, and then filling out the evaluation, completing that quiz. At this time, we can ask if anyone has any questions. You can type into that chat box. Oh, you're welcome, guys. My pleasure. I don't know how I. Do I know here? Okay, so if there are no questions, everybody, we're going to go ahead and sign off. We thank you for your patience as we work through our webinar issues over here.